Hello everyone, today we'll be discussing post-term pregnancy. So of note is there are two terms which you need to be able to differentiate, which is post-term and post-date pregnancy. So post-date pregnancy is any pregnancy which has passed beyond the expected date of delivery. And then for clinical purposes, a pregnancy continuing beyond 2 weeks of the expected date of delivery is what we call post-maturity or post-term pregnancy, which is more than 294 days plus 2 weeks. So the incidence of postpartum pregnancy is between 4 and 14% with an average of about 10%. So the etiology, the cause of the prolongation of pregnancy generally remains obscure, but there are certain factors that are related with post-maturity. The first one is wrong dates due to inaccurate last menstrual period, which is the most common. Two, biological variability, which is hereditary, may be seen in the family. So a patient will come to you and they'll tell you there's been a family history of delivering postpartum babies. Three, maternal factors, primiparity, previous prolonged pregnancy, sedentary habit, elderly multipara. For fetal factors, congenital anomalies such as anencephaly. So how does anencephaly lead to post-term pregnancies? So there's abnormal fetal hypothalamo pituitary adrenal axis, and there's adrenal hypoplasia, which leads to a diminished fetal cortisol response. 5, placental factors, which is sulfatase deficiency, which leads to low estrogen. Diagnosis. So the following are the useful clinical guides. One, menstrual history. So if the patient is sure about her date with previous history of regular cycles, it's a fairly reliable diagnostic aid in the calculation of the period of gestation. So the first thing you start with was when was your last menstrual period. However, you need to make sure that the patient previously had regular cycles and they're very sure of the date. Then the suggested clinical findings when a pregnancy overruns the expected date by 2 weeks are, so you look at the weight record, regular periodic weight checking reveals stationary or even a falling weight. Then girth of the abdomen, it diminishes gradually because of diminishing liquor. So I've noticed once the pregnancy reaches postpartum, the liquor starts reducing. History of false pain, appearance of false pain followed by subsidence is suggestive. Obstetric palpation, the following findings taken together are usually helpful to make a diagnosis of postpartum pregnancy. So investigations, so when you want to do investigations, your aims are to confirm the fetal maturity and two, to detect placental insufficiency. So how do you assess fetal maturity? You look at sonography, you can do amniocentesis on a straight x-ray of the abdomen. So amniocentesis, the biochemical and cytological parameters are usually helpful, which are going to be mentioned on the next page. Then straight X-ray abdomen, so thickness and density of the skull bone shadow, appearance and density of the ossification centers in the upper end of the tibia, which happens at 38 to 40 weeks, and lower end of the femur, which happens at 36 to 37 weeks, are taken together to assess maturity. So let's look at this diagram, which talks about determination of fetal maturity. So clinical, we talked about the last menstrual period, auscultation of the fetal heart rate, the fundal height, feel of the head, amount of liquor, and the cervical condition. Then investigation. So under non-invasive, we've got sonography and radiography. So under sonography, first trimester, you look at the crown rump length. Second trimester, you look at the biparietal diameter and the femur length. Third trimester, you look at the biparietal diameter, head circumference, abdominal circumference, and femur length. Then you also look at the amniotic fluid volume. Then radiography, more than 38 weeks, you'll also look at the ossification center, which is going to be at the upper end of the tibia and lower end of the femur. Then invasive investigations include amniocentesis, where you're going to note orange color cells, presence of phosphatidylglycerol, creatinine concentration, and spectrophotometric study. So complications of postpartum pregnancy include, so when pregnancy overruns the expected date, there is risk of placental insufficiency due to placental aging. So this is manifested by placental calcification and infarction. So fetal complications include during pregnancy, there is diminished placental function, there will be oligohydramnios and meconium stained liquor. During labor, there may be fetal hypoxia and acidosis. Labor dysfunction, meconium aspiration, there is risk of cord compression due to oligohydramnios. Shoulder dystocia, increased incidence of birth trauma due to big size of the baby, and non-molding of the fetal head due to hardening of the skull bones. 7, increased incidence of operative delivery. The main clinical significance of postpartum pregnancy is dysmaturity or macrosomia. So, following birth, they may present with chemical pneumonitis, atelectasis, and pulmonary hypertension due to meconium aspiration, 2 hypoxia, and respiratory failure, 3 hypoglycemia and polycythemia, 4 there is an increased risk of NICU admissions. The risk of stillbirth is also increased by about 3-fold from 37 weeks, which is 0.4 per 1000 births, to 43 weeks, which is 11.5 per 1000 births. Then maternal complications are increased morbidity incidental to hazards of induction, instrumental and operative delivery. However, of notice, post-maturity per se does not put the mother at any risk. So let's look at the scheme of management of post-maturity. So first you need to ensure that the fetus is mature, right? So fetal surveillance, you do an non-stress test, you do amniotic fluid volume estimation, biophysical profile, and Doppler velocimetry study. So if it's uncomplicated, you do an induction. So if the cervix is ripe, you do stripping of the membranes, you do artificial rupture of membranes. Then if the cervix is not ripe, what you do is you administer prostaglandin E2 gel 6 hourly. Once the cervix becomes ripe, you do artificial rupture of membranes. Then once you do your rupture of membranes, you take note of the liquor. Is it clear or meconium stained? If it's clear, you run an oxytocin drip and wait for expectant vaginal delivery. However, if you notice the liquor is meconium stained, you you do amnio infusion, electronic fetal monitoring. Then you do a scalp blood pH estimation. That is where CTG trace is available. Okay. Then if there is fetal acidosis, you go for cesarean section. If there is satisfactory fetal behavior, you do expected vaginal delivery. However, if you take notice that the post-maturity is complicated, so you incline more towards a cesarean section. If the cervix is unfavorable, go for cesarean section. If the cervix is favorable, do artificial rupture of membranes. You take note of the liquor. If it's clear, you do the usual. You do your oxytocin drip and expected vaginal delivery. If the liquor is meconium stained, then you follow the same algorithm we talked about earlier. So that's all about post-maturity. Thank you.